Hi everyone. My name is Sau Wai Chung, and today I'm going to talk about common chromosomal abnormalities. Today we will talk about why do we study chromosomes, and then followed by a brief history of cytogenetics and aneuploidies. Um, Usually, aneuploidy is one of the common chromosome abnormalities. Robertsonian translocation, one form of structural abnormalities. And then we'll talk about sex chromosome abnormalities. And then followed by the last, it will be briefly talk about clinical cytogenetics. So why do we study chromosomes? Because it's a major category of genetic disease. Chromosome aneuploidy is a major cause of pregnancy loss, abnormal pregnancy, and abnormal live births, such as congenital malformations, intellectual disability, about 10 to 15%, stillbirth, fertility problems, pathogenesis of malignancy. Approximately 0.2 to 0.3% of newborn infants are trisomic or monosomic. So there are some important days in the development of clinical cytogenetics. In 1923, a pathologist, Dr. Painter, established human chromosome number as 48 and identified the Y chromosome. So he noted that the XX as female and XY as male. Not until, so all the time from 1923 to 1950, until 53, Dr. T.C. Shu actually accidentally discover hypotonic treatment of cells to spread chromosomes. And then until 56, using this hypotonic treatment of hypotonic treatment of these metaphase cells, then we finally see that human chromosome is 46, not 48. So it's only until 1956 that we know that chromosome in only 46 chromosome in humans. And then in the 60s or early 59 to 60s, then Dr. Lu was identified trisomic 21 called Down syndrome. And then they have the first Paris chromosome conference. So in 1990, approximately, so all this time that we're studying chromosomes, and we also have high resolution bindings, and we study microdeletions in a chromosome way, So, and then not until 1990 that FISH became available, and that's the beginning of the molecular cytogenetics. We'll talk about that later, about FISH, how FISH is being done. FISH denoted as fluorescent in situ hybridization. At the same time, they also discover or describe the genomic imprinting and uniparental disomy. Understood the concept as an important mechanism of human genetic disease. In 1992, they developed the comparative genome hybridization, and that is using the cancer genome, the patient genome, co-hybridized with the normal genome and hybridized to the normal metaphases to see the copy numbers. In 1996, then because a lot of study in cancer, so they also have a sky spectral karyotyping using color FISH. And 2001, it started the chromosome microarray, but we clinically we're the first start 2004 have the chromosomal microarray is that the patient DNA co-hybridized with the control DNA, and then no, mixed with the control DNA co-hybridized to array of DNA whose location is known. So that's in 2000 and finally is 2004, which I will talk about in the next section. And 2010, array CGH became the first TA test replacing G-banded chromosome. So here is a karyotype, the G-banded karyotype, and you could see that the chromosome pair them from here to here, and then you have chromosome 1, 2, 3, 4, and so on. And then here is the I can use the so you can stand down in the right hand corner. That's the here. I can use it. Okay. Here is the X chromosome. And there were some terminology that you have to be a bit understand it that you could understand so that we could have some scientific common understanding. So we call this is telomere region. And before the array CGH, as a clinical cytogeneticist, you always look at the TER. Here is called the 1P TER, and here's the 1Q TER, and then 2P TER and 2Q TER. And this one, this is the centromere region. See, here is the centromere region. So we pair them based on pair them by the centromere and then the short arm and the long arm. And this we call homologous pair. And so you would have chromosome 1 to chromosome 22. And as I talk later on about these, because the short arm has genetic material, but it's genetically inactive. So we call these as acrocentric chromosome. So 13, 14, 15, 21, 22 are acrocentric chromosomes. So we also call that. The reason I mentioned these because when you read the literature, then you understand what they're talking about. So because it's in the middle, we call metacentric chromosome. And like this one, and this one, we call submetacentric chromosome. And again, as I mentioned earlier, these are acrocentric chromosomes. And here we call that the stop region and satellite region. And these DNA usually highly repetitive and it's genetically inactive. And later on, I also will talk about the X and Y. So this is the Y chromosome in the male, 46XY. And then they have from this region and this region called Part 1 because they share commonality. And then there's a few KB DNA are shared is called Part 2. And during meiotic pairing, so they would pair here to here and here to here. So therefore, it's kind of error prone because of the different sizes. And then we have this called International System for Human Cytogenetic Nomenclature. And the reason we use that is because from one laboratory to another laboratory, we had a common language. And this version keep changing every several years. Now I think that they have they are more frequent now because as the time goes by, we have more technology. When we have more technology, we need more nomenclature to communicate. And this one is a graphic representation of G bending pattern of chromosome. So we call that ideogram. And so here is the centromere, and here is the heterochromatic region. And then these bendings, and these are actually looks like our G bending pattern, but it's they make it graphically presentation. So here's the G banded, how we designate. For example, in the 400 band level, you had a lot less bending. You know, it's 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. So in here, for example, this is a chromosome 14. And then you have here's the P arm and here's the Q arm. You have the big 3 bands, 1, 2, 3. And then when you have more bands, then they subdivide it into 1, 2, 3. So it's 1, 2, 3. And here's the 1, 2, 3, 4. And the 3, we have 1 and 2. So if there's a missing here, then we will say deletion of 14q32, right? 14 chromosome Q3, 2. So that's first the arm and the region and the band. And then when we write it in a nomenclature, then we'll understand a director from another laboratory understand this is the portion is deleted. So so here is the nomenclature. For normal female karyotype, you have 46XX, and normal male then would be 46XY. I want to give you some example, and then the centromere, and then we had the deletion. Now I will show you a case of this is a relatively common structural abnormality, is deletion 5p, and so people will know that if the nomenclature says 46XX deletion 5p, that means that the patient had this individual has 46 chromosome, XX meaning it's a female, and then on the 5p is deleted. And that means it's a female with Chromosomal syndrome due to deletion of part of the short arm of chromosome 5. And I had some other example like the ring chromosome. Then we have 46X and then a ring chromosome. And then you have this, say you have a marker chromosome, meaning that you don't know the origin of this additional chromosome. Then we have because it's 47 counts. So it'll be 47XX plus marker. So female with the extra unidentified chromosome, and so forth. So these are the one that I had example, and we'll discuss it later. So this is the one that a patient with the Chromosomal syndrome, they have a terminal deletion. So you can see that this is the normal 5q, and then and this is the normal one, and that's the deletion is from here on. So from here on, we call that this band is 5p, the short arm, on the 1,5 and then 0.1 band. So it's at here. And patient with this deletion, they usually be detected shortly after birth due to a very high pitched cry. And the cry looks like it sounds like a cat cry. And usually these patients with microcephaly, dysmorphic features, intellectual disability, 10 to 11% of the newborn was born to a poor parent with a balanced rearrangement. So that's how we wrote that would be saying 46x for this patient with 46xy, comma, deletion, del 5, and then at which point there's what band, so it's P15.1. Here is the percentage, roughly percentage of spontaneous abortion and stillbirth. All the spontaneous abortions, about 50% of them, up to 12 weeks is 60%. 12 to 20 weeks will be 20%. Stillbirth is about 5%. And the incidence of these chromosome abnormalities in newborn survey, they find that all chromosome abnormality, the incidence is 1 in 160 live births. And they calculated, they study a large population and calculated the incidence. The Down syndrome is 1 in 800, trisomy 18 is 1 in 6,000, trisomy 13 is 1 in 8,000 to 1 to 15,000. 47XXY Klinefelter syndrome is 1 in 66. Remember that because the XY pairing, it increased the more risk in sex chromosome abnormalities. So therefore, the incidence is a lot is more frequent, a little bit more frequent than the other trisomies, other than the trisomy 21. So the first one is everyone very familiar with it, is the Down syndrome. The Down syndrome child, they have 47 chromosomes, and the number 47 chromosome is on chromosome 21. So when a child is born with this 47XY plus 21 is associated with Down syndrome. So this is the Down child. Once you saw it, you could spot it anytime when you see one. Down syndrome usually is associated with maternal age risk. So here's the table about the risk of the Down syndrome. And then there was also survey on maternal age at term. When maternal at term, the risk of Down syndrome is 1 in 350. And then as you can see, when the patient is 45, the risk is much higher, 1 in 35. 40 is 1 in 85. This is calculated at the maternal age at term. That's how we calculate the risk. When you see a patient, they say how my risk of Down syndrome, as the age, we make the breakpoint at 35. The 35 is because the risk of having an amniocentesis is lower than the risk of having Down syndrome. So that's why at 35 we will always recommend for amniocentesis. So the mammalian oocytes are particular error-prone in segregating their chromosome during the 2 meiotic divisions. So this is why that we need to study this, because why we have the maternal meiosis error causing Down syndrome, so that stimulate a lot of people start studying the mammalian oocyte. And here is the table, and here's the references if interest those that who are interested that aneuploid in human as the estimated levels at different stages. For example, spontaneous abortion in the 780s, the incidence of aneuploid is greater than 35%. Most common aneuploid is 45X plus 15 plus 16 plus 21 and plus 22. And usually, these are usually the most common one is 45X and plus 20 plus 16. When it's a pre-implantation embryo, in the 90s is 20 to 40%. A lot of them trisomy 16, 17, and 18. And when they're using fish to measure them, this is from 1990 to now, to the time it's studied, the 2012, is 25 to 70%. When they start using array to do the array and SNP arrays, 2000 to now, is the abnormality is 30 to 60%. So in order to understand the error prone, where's the error occur, we need to go back to study the meiosis. And I'm sure everyone have studied about meiosis. So I only emphasized certain point that's related to the maternal error. So you have two rounds of division, and DNA duplicated after that, followed by 2 rounds of division. And in meiosis 1, you will have a lengthy prophase. The lengthy prophase would have leptotin, cyclotin, pectine, diplotin, and dikinesis. And so, but during this diplotin stage, female germ sign tend to arrest, which I talk a little bit more in the detail. And then you would have first round of meiosis 1 and meiosis 2. So meiosis, when the start of meiosis, usually have 1 round of DNA duplication or DNA replication. And when after the replication, they enter the meiosis 1, then the chromosome are duplicated and forming pairs of chromosome, pairs of cystic chromatic exchange. And then when you go to cyclotin, they pair into single pair, a pair of them, and these we call homologous chromosomes. And when it enters the pectine, they start crossing over, recombining of the DNA. And then they keep on going to diplotin, and then go to anaphasis, and then start the second round of meiosis. In the end, after the 2 cell division to form gametes, and these are the gametes, and each with a half or haploid set of chromosomes. So in human, meiosis start after 3 months in the fetal development. And the 4th month, then they develop to have the 3rd month have the first meiosis, and then the 4th month they get into the cyclotin, and then 7th month they go to diplotin. At diplotin stage, they became arrest, and we call this was a dictotine, DICTYOTENE, dictotine. and this then they became arrest. And then at birth, there would be two times 6 to the 10 to the 6 oocyte were produced at birth, but 90% of them are degenerate. Now, over the years, 90% of them will degenerate at the onset of puberty. So about 200K of these 400K will ovulate over time. So just remember that in human, meiosis start during the fetal development, and then they undergo meiosis, and then at the diplotin stage, they became arrest. And when arrest, we give a term called dictatin. So here's why the human female mouses are so error prone. Because the egg was born, you're born with these eggs, and so the duration of the division is from 10 years when you start having the period to 50 years when you end the period. So again, as I mentioned, it began prenatally at 3rd month and arrested in the first meiotic prophase in a special stage called dictatin, only in female, and remains suspended until meiosis 1 is completed at ovulation. The surge of luteinizing hormone triggers both ovulation and the release from prophase 1 arrest and promotes the completion of meiosis 1 and extrusion of the first polar body. So remember that the DNA is duplicated and then forming, and then undergo meiosis 1, and they start having the ovulation start when the surge of luteinizing hormone. And then so you enter the meiosis 1. Not until fertilization, then so the meiosis 1, you have an egg, and then you have the first polar body. And then when fertilized, you go to meiosis 2. Then you would have the egg DNA and the sperm DNA fertilized, and then also the egg divided into then you have the polybody 2. So and then you enter the embryogenesis. And as I mentioned before, that just in prophase 1, you would have these cystic chromatids, and then you would have the homologous pairing, and then you have the chromosome, you have the crossing over. The crossing over, at the junction of the crossing over, we call chiasmata. And then here's the spindle. So the chiasmata is very important in the next slide. How did the aneuploidy arise? It's due to the mechanism known as non-disjunction. The term meaning that the aberrant segregation of homologous chromosome into the same daughter cell resulting in aneuploidy. And it could occur in all chromosomes. Most aneuploidy derive from errors in meiosis 1. Maternal age is a risk factor for almost all human chromosome trisomies. Alterations in the recombination are important contributor to meiotic non-disjunction. About 10 to 30% of fertilized egg had the wrong number of chromosomes. So here is the non-disjunction. So during meiosis 1, the both of the homolog goes to one cell, and then go to meiosis two, then you would have two chromosomes, and then fertilize with a sperm, then you have the third chromosome, therefore forming trisomy. And so the three of them hit the three of them are from different origin. Whereas meiosis two, this is meiosis one is normal, and then you have the non-disjunction. Non-disjunction, then you would have both of the duplicate one. So these two are similar origin, and then fertilized with the sperm, then you have the trisomy. And if by using different polymorphic markers, we are able to figure out whether it's meiosis one era or meiosis two era. And over the years, then we also study. So this field is quite very intense, especially in the early 2000 to 2000 to in the first 22 decade of the millennium. So why the human female meiosis are so error prone? So we have the non-disjunction, and then we study further about how that happened is because they have there's a cohesive tie holding to get together chromosome are weakened with the maternal age, and the study shows that actually the when you go into the high resolution, then you were able to study that there's a cohesion complex important for chromosome segregation and double-stranded break repair. So you form this cohesion complex, and this is known because all these genes, when they are defected, will have independent different abnormalities. Now that we know, so this cohesion complex is wrap around the chromosome, and it's only that they became loosened when they get ready to divide. And the disruption of this complex can lead to aneuploidy, defect in DNA repair, and chromosome translocations. So the chiasmata, as I mentioned, that the crossing over, like here, this is the chiasmata, and cohesion along cystic chromatid arms holding a homolog chromosome together prior to their segregation in anaphase 1. And these became very important. These cohesion holding the chromosome before they could divide. Now, if the cohesion during the age, as we age, this cohesion became deteriorated, and then leading to chiasmata slipping. So like as we age, these cohesions are getting loose and loose. So the chiasmata it used to be in here and gradually slipped through. And then once the cohesion lost the cohesion, these chromosomes became randomly distributed. So that's why some of the random chromosomes go to one cell and not the other, and then therefore you have the non-disjunction. They are also that the meiotic era are different. the study shows that, for example, trisomy 21, 85% the meiotic error is from from maternal side. And trisomy 18 is 90% from the maternal side. Turner is the interesting one, is that 80% of them are from the because of paternal meiotic error. And XXY is half and half. And 47XYY is 100% from the paternal meiotic error. So most trisomies appear to be caused by missegregation errors in the first maternal meiotic division, meiosis 1. Trisomy and monosomy can originate from meiotic or mitotic non-disjunction. Crossing over plays an essential role in maintaining cohesion between homologs. Trisomy is associated with reduced number of crossing over, often with the abnormal distribution either close to the telomere of the chromosome arm or conversely close to the centromeres. In some cases, no crossing over are detected, indicating the bivalent chromosome involved in the aneuploidy may have been no achiasmatic, meaning no chiasma. So non-disjunction means that absence or reduced level recombination or suboptimally positioned recombination events increase the likelihood of the non-disjunction. So this is the Down syndrome. The risk of have a pregnancy affected by Down syndrome is highly correlated with maternal age, increasing from 0.1% at 30 to 1% at 40. I have a side story to tell that in the late 70s, they just start having culture tissues and discover the Down syndrome. Well, we discovered the Down syndrome in the 59 already, but then we could culture them and make a diagnosis. So around that late 70s, then there was there's a lawsuit in New York because the lady gave birth to a Down syndrome child, and she asked the question. She said, "Can this be prevented?" And the answer was yes. And so she sued the OB guy, and she won for $5 million. This is 1979, around that time. So overnight, we a lot of the my classmate and I became a director instantly in 1980 because there was a big demand that a woman over 35 has to recommend for amniocentesis to rule out Down syndrome. So so this is a historical fact, And most common so this is the most common genetic cause of intellectual disability. And I mentioned before that it's low muscle tone, typical facial features. Half of the affected individual had cardiac defects. Now, so one figure, approximately 95% of the children with Down syndrome, the condition is due to trisomy 21. But another 5% is due to Robertsonian. So that's why I want to mention about Robertsonian in the later subsequent slide. So this is the meiotic non-disjunction that you have two trisomy and they go to the two of them non-disjunct go to the same cell as we age, and then fertilize with the sperm 21, then you got the trisomy 21. The other common one is trisomy 18. In the old days, we consider trisomy 18 is lethal. This old days meaning that before 2000 or before in the 80s. Because these patients, they either die in utero or even they give live born, they usually pass away within the first year. And even you rescue them, and they still would die. So some parent in those old days, they want to, of course, if your first child is trisomic 18, you want to do everything to save life. So what happened was that these patients, in the beginning, the parent want to save the baby, and then of course you're using all kinds of medicine all kinds of technique that medicine can afford to save the baby, but in the end the baby died in the first year. Then the parents settle with a huge medical bill. So because of that, that we consider that the trisomy 18 is lethal, and we sometimes using stat bone marrow to figure out that it's just trisomy 18. If it's trisomy 18, then we will not treat them, and then that will save a lot of the healthcare cost. So trisomy 18 is 1 in 6,000 live births, 95% spontaneous abort, and usually this is the picture you saw on the right, that they had growth retardation, small eyes, small mouth and chin, overlapping fingers, rocker bottom feet. And trisomy 18 is because you have 47 chromosome and it's a male, and then on the chromosome 18 you have 3 of them, so that's called trisomy 18. The next one is trisomy 13. Trisomy 13 is one incidence, 1 in 8,000 to 15,000 live births. Trisomy 13 is similar to trisomy 18. 95% of them are spontaneous abort, and they have clefting abnormality, scalp defect, polydactyly, and holoprosencephaly. So these are very that we consider lethal because they usually die in the first year. And trisomy 13, you can see that this is a 47 chromosome, and it's a female XX, and on chromosome 13 you have 3 of them, so that's how we diagnose that as trisomy 13. The newest study showed that most are maternal in origin, 89% of them, and it could be one or meiosis II error. Triploidy. Triploidy is interesting. It can be 67XXX or XXY or 67XYY, and 1 to 2% of conception. Most often is used because 2 sperm fertilize 1 egg, and then you have 3 sets of chromosomes, and that's why you have the triploidy. And actually, it's pretty common too. And here is you see the 3 chromosome 1, 3 chromosome 2, and all the way down is 3 chromosome X. So 69XXX. So I want to mention briefly of Robertsonian translocation in relation to Down syndrome. So Robertsonian translocation, among most common balanced structure rearrangement in general population. And frequency is 1 in 1,000 from newborn survey. 45, so normally if it's a carrier, you will have 45X X or XY, ribosome 13 and 14 accounts for 75% of all ribosomal translocation in unbiased study. And it usually is because remember I mentioned about the acrocentric chromosomes. So one of the acrocentric chromosome, like the 21, translocated to 14, then became a ribosomal translocation because this satellite. I remember I mentioned about acrocentric had a lot of satellite material and they're repetitive sequence and they're genetically active, but they could pair them. They sometimes, because these are sequence homology, they accidentally pair them together and form this ribosomal translocation. So basically here you can see that these groups that they have acrocentric, these are acrocentric, and these sequences are similar, and sometimes they error prone, that they would crossing over between, they're prone to crossing, they tend to pair them together, or they tend to cluster together, and then crossing over occur, resulting the ribosomal translocation. So here's about 3 to 4% of Down syndrome case. The extra chromosome material is the result of unbalanced translocation between chromosome 21 and another chromosome. So in this case was that the 21 goes to chromosome 14. So you have 45, if it was a carrier, you have 45 count because the carrier also carry the one of the 21 at the 14. So the risk of unbalanced offspring in female, if 14, these are the data, these are the actual data we study and come up with this conclusion that 41-21, the recurrent risk is 10 to 14% in female, but for male is a lot less. And 21-22, 21q, 22q ribosomal translocation in female, the recurrent risk is 7%. On 21-21q, the recurrent risk is 100%. I could show you the picture. Okay, so if the mother carries a 21 carrier, is 45 counts, right? Because the other 21 is here. And so the possible egg would be, one is like this and the other one has none. So when fertilized with a normal sperm, so 100% you would get the recurrent risk is 100% for patient like this. But however, a majority of the translocation down usually are de novo. Now we talk about the 6 chromosome disorders. Chromosome abnormality in the first trimester, spontaneous abortion. In this study, the chromosome is the frequency is 11%, but in breaking down, 45X is 5.7%, triple X is 1.5%, XXY is 3.4%, and XYY is 0.3%. And the X chromosome is larger and more gene-rich than the Y chromosome. It has 1965 genes, 2.3 times the size of Y chromosome. The length is roughly 155 megabase, and have 5% of the total genome. Y chromosome contains about roughly 60 megabase, or 1.9% of the total genome, with 421 genes. So here is the as I mentioned before, so here's the X chromosome, and here's the X inactivation center, and here is the PAR. This is the PAR region. Would be PAR with PAR one. They're sharing the common, so they're during meiotic pairing, they would pair with this, and here is the PAR two. So usually you would see a picture like here, and then like this, and then like that. So that's the X chromosome. And because of this pairing structure, usually it's a little bit more error prone. So pairing and recombination between X and Y chromosome during male meiosis occur between homolog segments of so-called pseudo-autosomal region, PAR region. The pseudo-autosomal region, PAR 1 and PAR 2, have Y chromosome homolog and therefore are not inactivated and remain active. The end of the XP and YP, or the PAR region 1, that means it's here, are 2.6 megabase in size with 24 genes in transcript. The end of the part two, the end of the XQ, YQ, or part two region has 330 kb in size with 8 genes and transcript. X chromosome deletion of the PAR1 region result in failure of pairing and male sterility. All characterized genes with PAR1 escape X inactivation. Approximately 5 to 10% of additional gene on the X chromosome outside of the PAR region also escape X inactivation. So the most common one is a Turner syndrome. Turner syndrome actually had quite a bit of a variety, which I will show later. The incidence is 1 in 2,500 live births, very common in first trimester abortion, and as many as 99% of the 45X embryo die in utero, not associated with advanced maternal age. 70% of all cases are paternal in origin. So this is the Turner syndrome. You have 45 chromosome with 1X. 46 you have 2X. 45 is meaning that you're missing 1X chromosome. And these are the pictures of Turner syndrome. Two main features of Turner syndrome. Girls are usually shorter than average. The average adult height of a woman with Turner syndrome is about 4 feet, 8 inches. Gonadal failure, strict gonad, infertility, and hypogenitalism, lack of sexual development is usually associated with Turner syndrome. The Turner syndrome, instead of genetic-wise, had a lot of spectrums. Most common was 5X, but you could also have iso-XQ. You could have also mosaic, so have 3 different cell lines, and you have Y chromosome like dicentric Y. You have a mosaic for marker chromosome. You also have 45X and 46XY in the body. And you could also have 40X and then deletion XQ. Other ones were like the ring X or a marker chromosome later on we find was X, and these are the roughly percentage. In the case of ring chromosome, ring autosome translocation, the incidence of the intellectual disability and other congenital abnormality can be significantly higher, which I will explain in the next slide. So chromosome of Turner syndrome, usually one of the form would be mosaicism with 2 or more cell lines in 25% of the cases. 45X, 46XX are most common. And it usually increase of course, it will be increased phenotypic variation depending on the percentage of the cell, and then also the potential, the distribution depending on the percentage and the distribution of the abnormal cells during development. And you also had increased risk of having 45X and 46XY. And that's why at birth, when you have a child with the Turner syndrome, we always send for blood to test to rule out mosaic XY, because if the child born with the 45X and 46XY, and that XY would develop into gonadal and then you also had 3 cell lines, and you also had 45X, 47XXX. All this we lump it as a Turner syndrome. The other type of Turner syndrome involving structural chromosome abnormalities. For example, as you can see, isochromosome for the long arm of X. So you could see that in here, there's a normal X chromosome. Here's the centromere, and XP and XQ. And in here, you see that was the 2 long arm, a mirror image of 2 long arm and lack of the short arm. So this is the diagram, ideogram shows that there's a normal X chromosome, and because the central division, abnormal centromeric division, and this one get lost, and then you have 2, and therefore you have this is one kind of Turner syndrome. Or you could have, it depends on the break point. The break point in the centromere, then you have 1 centromere. But most of the time, the break point is on a short arm. So then you will have a dicentric iso XQ. So the incidence of 15% among Turner's patients, usually also in mosaic state, and phenotype may be virtually the same as those Turner 45X karyotype. And you also have the XP deletion, and so you have this deletion of the XP, and you also have the deletion of XQ. There would be, as I mentioned earlier, that this is a 46X and then ring chromosome. So this is the ring chromosome, and you use FISH. You could see that the centromere is this is a normal X chromosome, and here's the ring with the X centromere. And remember earlier I said about X inactivation center is around here. If the ring escape X inactivation center, then this will be active. So sometimes you see Turner plus marker chromosome, and the patient was has severe intellectual disability. That's because they have the X, and then they have this active piece of chromosome X too. This is the one that I mentioned about the marker chromosome. It turned out to be X chromosome origin, and if this is huge, if it's not involving the inactivation center, these would be active. So the next one is Klinefelter syndrome. 50% of a paternal origin and 50% maternal origin. Yeah, and the Klinefelter syndrome, the first patient I saw usually is you go to adult clinic, and it's a male, and they don't have any children, and so sometimes we, go through life without knowing that without knowing that he had Klinefelter syndrome. But then in later age, other things develop. Then find out that was Klinefelter. They usually tall stature, slim, long limbs, tendency to obesity, small testicular atrophy after puberty with halination and fibrosis of semiferrous tubules due to excessive gonadotropins. And actually, nowadays, these patients can be treated. So Klinefelter is 47 chromosome, and then you will see additional X chromosome, usually it's X and Y, but Klinefelter will be 2 X's. Phenotype is presumably to be consequence of presence of a non-activated extra X from the X chromosome. They have a intellectual disability and other behavior problem. The last 2 slides I will mention about the Y chromosome deletions. If deletion Y cubed from here to here, usually will cause infertility or non-obstructive azoospermia or oligospermia, because all these factors are distributed here. Deletion of YP, that's the SRY gene, and then if you have the deletion of the Y gene, then you will become XY female. And this is a cause for in the Q, the YQ, the men with AZFA, AZFB, AZFB and C microdeletion uniformly had complete absence of spermatogenesis. Klinefelter syndrome is the most common chromosomal abnormality and the most common genetic cause of azoospermia. Men who have non-obstructive azoospermia or severe oligospermia with total mobile count less than 5 million should have a karyotype and testing for Y chromosome microdeletions. So this is the end of my talk for today.